Moderator, Kelly. Good afternoon, everyone. Today we're going to talk about a relatively new approach to a relatively old technology, a change in how we look at compression therapy, and a device that I've been using in my clinic, sequential contraction compression therapy, which generates the compression through a new way, and how it affects the vasculature. And if we get started, what is this? Oh, there we go. So sequential compression, it's a novel technology. It activates the natural muscle pump, causing an increase in arterial and venous circulation. It works really in one direction only. It compresses the muscles of the leg, and thereby compressing the veins of the leg, helping with venous outflow. As a secondary consequence, it allows for, in between pulses, it allows for increased arterial inflow. Okay. As my mother taught me to sing when I was little, make new friends but keep the old. If we look at intermittent pneumatic compression and what we traditionally use, the boots and stuff like that, they're bulky, they're costly, they're complicated to use, they're uncomfortable, they're noisy. There are complications to them in that the tubes kink, the generator doesn't always work. There's poor compliance because of that, and because patients don't like to sit in one place for 2 or 3 hours at a shot. On the other hand, in the plus column for them, there's a lot of proven technology and a lot out there in the literature that says that it's good and that it works. And we know that it's been proven from everything from ulcerations all the way down to the underlying disease of the circulatory disorder. If we look at it, the sequential contraction compression devices, it's small and self-contained. It's cost-effective because it's relatively cheap. It's very easy to use in that it has only one button, well, 2 buttons, on, off, and a higher and lower. It's pain-free and it doesn't restrict activity, so patients are able to get up, walk around, do whatever they need to do while they're being treated. And because of that, we get a lot more positive compliance, which in my office in particular, dealing with mostly diabetics who are known compliance penic, we get a lot better there. And it's got a pretty good track record in the few hundred devices that are out there being used. And just in comparing the mechanism of action and the results to what's out there in the literature, it's got something to stand on. Okay, the indications for the use are pretty much the same as the IPCs. Peripheral arterial disease, chronic venous insufficiency, edemas and lymphodemas, DVT prevention, and pain and muscle atrophy, and diabetic peripheral neuropathy. I've been asked a lot about this. John, you're crazy. What does diabetic neuropathy have to do with vascular disease? And I'll tell you that this is some work that we've done with a group in England out of Nottingham, not with the sheriff and not with Robin Hood, but with a guy named Solomon Tesfaye, a brilliant endocrinologist who's out there. And he basically, in his pathology lab, found that there's a real paradigm shift in how we look at neuropathy. We believe that while it is certainly metabolic in nature, there's a significant vascular component on a microcirculatory level, in that the same way that in venous disease, when we biopsy an injured vein, there's oftentimes a fibrin cuff either around the vein or in a feeder vessel. The same thing we find in the feeder vessels and the capillaries into the nerves, so that if we're able to hyperperfuse the area and get some blood through that cuffed off capillary, we're able to reperfuse the nerve and rejuvenate it, if not regenerate it. It causes three peristaltic contractions from distal to proximal. Dr. Shurkin can see it and vouch for it. Okay, and what it does is by doing this, it's allowing for venous outflow up through it. The reason that it does the contractions in sequence is that if we look at it if we were to think of a straw, or me squeezing the middle of the microphone, some blood would come up, but some would come down. If I was able to squeeze it here and hold it closed and then squeeze again higher up, I'm getting more of the blood coming up. Okay. And here, if we look, we have some Doppler waveforms that we have on the left side. Left by you also? Yes, on the left side, you can see that the pulses are very low, even though they're ordered. So there is good flow, or there is some flow, and the width of the blue in the color Doppler is moderate. It's significantly increased if we look at the Doppler waveforms in the active, when the device is actually on. We have a significant increase both in frequency, although the frequency is modulated by the device itself, but the actual pump, the height of the pump and the pulse is much higher. And if we look at the actual Doppler wave, at the color Doppler, all of the numbers, both in the velocity and the width of the vessel, is higher. If we look at it another way, this was a patient of ours in New York, not actually in Israel. This is digital infrared thermography, which is, I actually saw outside that FLIR had, their camera. This is becoming more and more popular in the diabetic, foot care world, and certainly I'm sure in some of the research labs. If we look at her right foot, which would be on the left side, yes, that is all of one woman, by the way, female patient. That's as much as I'm going to give away. But if you see the blue is very cold, that's pre-treatment, and just by activating the device for about an hour, we increased the circulation in her leg significantly. This was a venous insufficiency patient, and this is a ischemic leg. Okay, if you look at the left hallux, you can see just how icy cold it is, and you see that she's got pretty good pulses. So this would be a patient with palpable pulses. So you're kind of, she was a dialysis patient, which Dave Armstrong calls the great equalizer. And it really is. We were doing a research study out in Shari Tzedek by us in Jerusalem, where the distribution of dialysis complications in the toes is actually very similar to radiation poisoning. And one of the things we found is one of the components to dialysis is actually uranium. So there may be some propensity to some seeding of radiological substances in the toes which mimic radiation poisoning. But more importantly, if we look and see just how ischemic her toe is, and you can see in the clinical picture to the right that she's about to lose a significant amount of her forefoot, and she was actually scheduled for a transmetatarsal amputation. If you look after just a little bit of treatment, at the bottom picture on the left, you can see that even though she's missing a little bit of her hallux, the rest of the forefoot is very healthy and nice and pink. And if you look at the clinical picture, she did only lose a little bit of the hallux, but the necrotic tissue on the other toes was saved. Okay, does it work? So there are 6 papers right now out there submitted for publication, 2 of them dealing with peripheral arterial disease, looking at subjective data of pain and foot temperature, 2 on neuropathy. One is about a hypoaesthetic patient, and one is hyperaesthetic, and I'm going to go back to that because neuropathy happens to be my favorite thing right now. A venous insufficiency study looking at limb circumference and quality of life, and one just discussing the mechanism of action and the blood flow and the circulatory velocity. There are about 400 patients who have them. There are no adverse events. There's a high patient satisfaction rating, and again, most of it is because it's been on me the whole time now. You see that it doesn't affect what I'm doing. You're able to walk with it, talk with it, whatever you need to do. Going back again to the neuropathy, this was a paradigm shift and was something very exciting for me to see from outside and then to contribute to it from inside. The whole approach to neuropathy is changing and is about to change drastically. And it comes about even in the treatment approach to it, where even the drugs are less indicated towards the neurologic and metabolic component of it, and a lot more vascular in nature. And we see a line of continuum also between the hyperaesthetic and the hypoaesthetic, where one will often turn into the other. Oftentimes you'll get the hyperaesthetic where the patient feels significant pain just from blowing on it even, to where they progress to full numbness. And one of the most satisfying things for me, other than seeing a patient lose pain though, is when they finally, a patient who might not have felt the floor or has problems walking because of balance and is able to finally get back on and, you know, say that they feel the floor or they feel whatever it is and they get their confidence back, that's very gratifying. Conclusions. It's an interesting new device. I say new, it's been out there for a couple years. There are many clinical indications for it. It's very safe and it's an effective way to deliver compression therapy. I say it's effective to deliver the compression therapy because anything that a patient will use is effective. Patients do not like compression stockings, particularly where I come from in Israel, where the weather is warmer than cold. And boots are, while they deliver the goods, boots are cumbersome and patients do not use them as much as they should. It's efficacious. It would benefit from some more RCTs and we're getting ready for that. And it's enabled a new look at neuropathy, which anytime you get a new look at something, it's always very exciting. And thank you very much. And now, if anyone has any questions.